Physical therapists, we focus a lot on muscles, bones, joints. We help people recover from injuries. We teach them how to move better and get stronger. But there's a powerful and often overlooked system that fuels every single movement. I'm talking about the respiratory system. Your lungs are the engine that provides oxygen to every muscle cell in the body. Without efficient breathing, recovery stalls. Simple exercises become monumental tasks. Think about it. Every squat, every step, every stretch relies on a steady supply of oxygen. If that supply is compromised, the entire kinetic chain breaks down. It's not just about strength. It's about the very energy needed to create that strength. Imagine your patient is working hard to recover from a knee replacement. They're doing their exercises, but they get out of breath almost immediately. They feel dizzy and fatigued. You might think they're just deconditioned from the surgery. But what if the real problem is underlying lung trouble? What if their lungs can't keep up with the oxygen demand of the exercises you've prescribed? This scenario is incredibly common. The patient's motivation drops. Their progress hits a wall. This is precisely why understanding pulmonary health isn't just a bonus for a PT. It is absolutely essential for providing truly holistic and effective care. The connection between breathing and movement is direct and profound. Efficient breathing mechanics support good posture. A strong diaphragm, our primary breathing muscle, contributes to core stability. When a patient can't breathe well, they often compensate with other muscles. They might use their neck and shoulder muscles to gasp for air. This leads to tension, pain, and poor movement patterns. So, the neck pain you're treating might actually be a symptom of a breathing problem. By only focusing on the musculoskeletal side, you're missing a huge piece of the puzzle. You're treating the symptom, not the root cause. So let's reframe our thinking. Let's start seeing the lungs as a core component of the musculoskeletal system. They are not a separate entity. They are deeply integrated into everything we do as physical therapists. When you assess a new patient, you should be thinking about their breathing just as much as you think about their range of motion, or their muscle strength. How is their breath at rest? How does it change with activity? Recognizing the signs of poor respiratory function is a clinical skill that will elevate your practice. It will allow you to design safer, more effective treatment plans and truly help your patients achieve their maximum potential. So what exactly are we talking about when we say pulmonary pathologies? It sounds complex. Let's break it down. Pulmonary, chakra the lungs, pathology, chak the study of disease. So pulmonary pathologies, chakra diseases of the lungs and respiratory system. These conditions can make breathing difficult. They interfere with the lungs' main job, taking in oxygen, getting rid of carbon dioxide. Gas exchange is vital for life. It fuels every cell, brain biceps. When disrupted, effects are everywhere. For a physical therapist, this matters. Your patients will have limits beyond a weak muscle or a stiff joint. Their entire energy system is compromised. They experience shortness of breath, dyspnea. They tire very easily. Imagine doing exercises while breathing through a tiny straw. It's exhausting and frightening. These are functional issues that block therapy and life. Understanding the diseases is the first step to helping patients manage them. Pulmonary pathologies split into two categories. First, obstructive lung diseases. Problem, getting air out. Think blockage in the airways. Air gets trapped, hard to exhale fully. Result, can't catch your breath. Second, restrictive lung diseases. Problem, getting air in. Lungs are stiff or restricted. They can't expand fully. Reduced capacity, like inflating a leather balloon instead of rubber. Both types create unique challenges. Obstructive, short bursts. Okay, sustained effort fails. Restrictive, trouble with deep breath activities. Lifting something heavy, climbing stairs. Knowing the type changes your approach. It guides exercise prescription, pacing, educational strategies. Let's dive into one of the most common obstructive diseases. Chronic Obstructive Pulmonary Disease (COPD). This is an umbrella term that primarily includes two conditions, emphysema, chronic bronchitis. The main cause of COPD is long-term exposure to irritants that damage the lungs and airways. The number one culprit is cigarette smoke, long-term exposure to air pollution, chemical fumes, dust. Over time, this damage is progressive and irreversible. It makes it harder and harder to breathe. For patients, it feels like they are carrying a heavy weight on their chest all the time. In emphysema, the tiny air sacs in the lungs, called alveoli, are destroyed. These are the delicate structures where the magic of gas exchange happens. As they break down, the lungs lose their natural elastic quality. Air gets trapped in the damaged sacs, making it extremely difficult to push air out. In chronic bronchitis, the airways become inflamed and narrowed. The lining of the bronchial tubes produces a lot of thick mucus. This clogs the airways, leading to a persistent hacking cough and severe difficulty with breathing. Many people with COPD have a combination of both emphysema and chronic bronchitis, creating a dual challenge for their respiratory system. The symptoms of COPD develop slowly over years. A person might first notice a nagging cough, getting winded more easily during activities they used to handle with ease. This is often dismissed as just getting older, but as the disease progresses, the symptoms become impossible to ignore. Patients experience constant shortness of breath even at rest. They have a chronic cough that produces mucus. They often have wheezing and a feeling of tightness in their chest. The effort of breathing is so immense that it can lead to significant weight loss and muscle wasting. For a physical therapist, understanding this process is crucial. When a patient with COPD comes to you, their body is already in a state of chronic stress and energy depletion. Pushing them too hard can be dangerous. Your job is not to cure the disease, but to help them manage it. You need to teach them how to conserve energy. You need to help them clear their airways of mucus. You need to prescribe exercises that strengthen their breathing muscles without overwhelming their compromised system. It's a delicate balance that requires knowledge, patience, and a deep sense of empathy for the daily struggle these patients face. Now let's talk about another common obstructive lung disease, asthma. Unlike COPD, which is progressive and constant, asthma is episodic. It has attacks. It's chronic and causes airway inflammation and narrowing. But this can be reversible. The airways are hypersensitive. They overreact to triggers. Common pollen dust mites, pet dander. Other triggers: cold air, exercise, stress, respiratory infections, like the common cold. The unpredictable nature of attacks makes asthma hard to manage. During an attack, 3 things happen in the airways. First, the airway lining becomes swollen and inflamed. Second, the muscles around the airways tighten, bronchospasm. Third, the body produces extra mucus, thick and sticky. That mucus can further clog the already narrowed airways. The combination makes breathing very difficult, especially breathing out. It's like trying to exhale through a pinched straw, a frightening experience. Classic symptoms are easy to spot: severe shortness of breath, a high-pitched wheeze, a persistent cough, tightness or pressure in the chest. In a severe attack, they may be unable to speak more than a few words. They may appear anxious, pale, and sweaty. This is a medical emergency. Immediate action is required. Quick relief inhalers, like albuterol, open the airways. As a PT, know your patient's asthma history. Know their triggers. If exercise is a trigger, plan sessions carefully. This doesn't mean no exercise. Exercise is beneficial. Always include a proper warm-up and a proper cool-down. Encourage rescue inhaler use before sessions if indicated. Monitor for signs of an attack and know exactly what to do. Help them build fitness safely so they can live an active life without fear. Now let's shift our focus to the other major category, restrictive lung diseases. Remember, with these conditions, the problem isn't getting air out, it's getting air in. The lungs lose their ability to expand fully. This reduces total lung capacity. Imagine your lungs are in a corset that's just too tight. No matter how hard you try to take a deep breath, you can't fill them up all the way. That limits oxygen getting into the bloodstream with each breath. There are many types, grouped by cause. Some are intrinsic. The problem is the lung tissue itself. Idiopathic pulmonary fibrosis, or IPF. Lung tissue becomes scarred and stiff over time. Scar replaces healthy elastic tissue, making expansion difficult. Other intrinsic causes: sarcoidosis, which involves inflammation in the lungs. These change lung structure and compliance. Other restrictive conditions are extrinsic. The problem is outside the lungs. Lung tissue may be healthy, but something physically prevents expansion. Chest wall problem, severe scoliosis compressing the chest cavity. Extreme obesity restricting chest and abdominal movement. Neuromuscular diseases, ALS. Neuromuscular diseases, muscular dystrophy, weakening respiratory muscles and diaphragm. Primary symptom, progressive shortness of breath, especially with exertion. Patients often have a dry, hacking cough. They breathe rapid and shallow. Deep breaths are difficult and uncomfortable. They can't get a satisfying full breath. This leads to profound fatigue and reduced ability to do daily activities. For a PT, focus on maximizing available lung capacity and improving breathing efficiency. So now that we understand these conditions, why is it so critical for a physical therapist to be an expert in this area? The answer is simple. Breathing is movement, and movement is our domain. When a patient has a pulmonary pathology, their entire quality of life is affected. They might struggle to walk to the mailbox, they might not be able to play with their grandchildren, or even just take a shower. As PTs, we are uniquely positioned to intervene. We can bridge the gap between medical management and the patient's functional goals in daily life. We don't just treat a diagnosis, we treat the person living with that diagnosis. First and foremost, a deep understanding of these conditions ensures patient safety. Prescribing the wrong type of exercise or pushing a patient too hard can be dangerous. For a patient with COPD, high-intensity exercise might cause a dangerous drop in oxygen levels. For a patient with exercise-induced asthma, skipping a proper warm-up could trigger a severe attack. By understanding the pathophysiology, you can monitor vital signs. Oxygen saturation, heart rate, perceived exertion. You can recognize warning signs and know when to stop or modify an activity. This knowledge transforms you from an exercise instructor into a skilled healthcare provider who can safely manage complex patients. Beyond safety, this knowledge allows for effective and individualized treatment planning. A one-size-fits-all approach will fail these patients. A patient with COPD might need breathing techniques to get trapped air out, like pursed lip breathing. A patient with a restrictive disease like pulmonary fibrosis might benefit from techniques that improve chest wall mobility. Strengthen the diaphragm. A patient with asthma needs a program that builds aerobic fitness gradually to reduce the risk of exercise-induced attacks. Your understanding lets you choose the right tools from your PT toolbox for maximum impact. Finally, our role extends to education and empowerment. Patients with chronic lung disease often live in a state of fear. They are afraid of becoming short of breath, so they avoid activity. This leads to a downward spiral of deconditioning, which makes their breathing even worse. We can break this cycle. We can educate them about their condition in simple terms. We can teach them strategies to manage their breathlessness. We can show them that they can be active safely. By empowering them with knowledge and skills, we give them back a sense of control over their bodies and their lives. This psychological component is just as important as any physical exercise. So what are these practical interventions? What can we actually do in the clinic to help these patients? One of the most powerful tools is teaching specific breathing techniques. For patients with obstructive diseases like COPD, the go-to technique is pursed lip breathing. Inhale slowly through the nose for 2 counts. Exhale gently through pursed lips for 4 or more counts, like blowing on hot soup. This creates back pressure in the airways and helps keep them open longer. That lets trapped air escape and relieves breathlessness. It also improves gas exchange. Another key technique is diaphragmatic, or belly breathing. Many people with lung disease overuse their neck and shoulder muscles. That pattern is inefficient and wastes energy. We retrain them to use the diaphragm, the large dome-shaped muscle at the base of the lungs. Have them lie down and place one hand on the chest and one on the belly. Instruct them to breathe so the belly rises while the chest stays relatively still. This strengthens the diaphragm, reduces the work of breathing, and promotes relaxation. It's a foundational skill for better respiratory function. Exercise is a cornerstone of pulmonary rehabilitation, but it has to be the right kind. Interval training often works better than continuous exercise. Example: walk on a treadmill 2 minutes, then rest 1 minute, repeat. That allows higher intensity training and greater gains in cardiovascular fitness and muscle strength, all without becoming dangerously breathless. We also incorporate strength training for the large muscles of the legs. Stronger legs need less oxygen to do the same work. Finally, airway clearance techniques help patients who produce lots of mucus. Chronic bronchitis, cystic fibrosis. Teach an effective huff cough, less tiring than a forceful cough. Use manual techniques like percussion, rhythmic clapping on the chest with cupped hands to loosen mucus. Combined, these techniques, breathing exercises, and a tailored exercise program can dramatically improve daily life. Reduce hospitalizations, improve exercise tolerance, give patients the confidence to live more fully despite their diagnosis.